Welcome, everyone. This is the Bioethics Interest Group webinar at George Washington University, and we're very excited to have you here today. Today, we're going to focus on ethical challenge in mental health research and practice. We have two extremely well-experienced panelists today who I am very happy to welcome, as well as my colleague, Paul in ballet. And briefly, I'll introduce our panelists, and then we'll get started with their presentations. First, I'd like to introduce Dr. Philip Candilis, who is here at George Washington University. He's a professor of psychiatry and behavioral sciences, chair of the ethics committee of the American Psychiatric Association, director of medical affairs at St. Elizabeth's Hospital here in Washington, D.C., and works here at the Department of Behavioral Health in the School of Medicine and Health Sciences. We're very happy to have Dr. Candilis, and he'll be our first speaker. Our second speaker is Dr. Celia Fisher, who holds the Marie Ward Doty University Chair in Ethics and is a professor of psychiatry at Fordham University in New York City. She's also the director for the Center for Ethics Education, HIV and Drug Abuse, and Prevention Research Ethics Training Institute and Human Development and Social Justice Lab. We're very happy to have Dr. Fisher, and we're grateful that both of you could join us today. Dr. Candilis, I will turn it over to you now, so please share your slides when you're ready.
Thank you, Dr. Goldstein. A pleasure to be with you. My thanks to you and the Bioethics Interest Group for putting the focus on mental health, a good time for it. And our thanks to Dr. De Pelle, and as well as our friends at the School of Public Health, Mr. Imamote Bega and Ms. Nia Nator, who've kept us on course as we plan this. So what I'm going to be doing is talking about some of the important movements that have put the focus back on mental health in recent years, and give a general overview of the ethics principles and guidance that help us get through it in organized psychiatry. And I'll focus on our research here at GW as well as the public sector. And lead among the new sensibilities is the pandemic and the after effects of the many years of quarantine and isolation, which we now think created too much of a burden on our children in the schools because they had less access to socialization, they had less access to healthcare, there was less surveillance and monitoring of their health during that period, and certainly a lot of fear of COVID. And certainly the effects on families were similar. We saw an increase in the purchase of weapons, of handguns, use of alcohol, intimate partner violence, ER visits. We did a webinar with some of the folks from the statistics branch over at NIH, and they were tracking the communities that had the most difficulty during COVID. And as you can imagine, they were the minoritized and marginalized populations. And then you look at the constant media focus on the pandemic, and then the doom scrolling that we do on social media during that period, and all of it had an effect on depression and anxiety rates and substance abuse. Now there was, in the view of many of us, a robust social response. So CMS, Centers for Medicare and Medicaid, expanded telehealth access so we could get into rural areas, so we didn't have to work with patients directly and expose them and us who were in the healthcare settings to infective vectors to the illness. There was increased funding. We paid a lot more for our clinicians and a lot of educational efforts. And this is the classic tension during epidemics, this balance of public safety and individual freedom. So the objections to quarantine and isolation and vaccination, mandated vaccination, especially for healthcare workers, is just this classic struggle which goes back centuries. I mean, medical ethics itself came out of an epidemic in Manchester, England, when Thomas Percival was asked to write, essentially a guide for behavior, and the AMA adopted those ethics for the U.S. But this struggle goes back centuries. The initial impulse is always to quarantine and isolate, and we just lived through it. It's that balance that creates the problem for communities. If you also look at returning warfighters, the veterans who were coming back from Afghanistan and Iraq, it was very clear that their rates of suicide, PTSD, traumatic brain injury were higher than what we'd seen in the past. And this created an extraordinary need that the VA had to respond to. So what they did was to increase screening and resources and support for families as well. They broadened their efforts in public-private partnerships, some of which you see on the right here, and the NGOs kicked in as well. It created a sea change because they also offered grant money to many of the universities to study and to oversee this kind of problem. I mean, these are people who are coming back um, from wartime settings and have access to weapons. They're experiencing the depression, anxiety, the PTSD type symptoms that we know about from previous conflicts. And they create this focus on vulnerable populations and values. This is what those of us who are writing on professional ethics, we don't like to focus so much on principles and balancing anymore. We like to prioritize those people who are vulnerable to the issues, the influences of difficult settings and difficult times. So we prioritize marginalized populations, minoritized groups, or those that are particularly vulnerable. So if one doesn't have access or is not equitably treated by a healthcare system or a community in general, they deserve prioritization. We also have movements in sports. So sports figures have been increasingly public about their struggles with mental health. This actually just saw a story in the Washington Post not last week about football players who were trying to protect each other from reporters' questions. There was some mental health issue. Teammate and other teammates were coming to his defense, saying, "Look, leave the guy alone. Give him an opportunity to get his head straight and focus more on the game, on the work, rather than his mental health issue." And probably the most prominent figures for this issue are Simone Biles and Michael Phelps. You may recall Simone Biles, world champion, Olympic champion, gymnast. She reported experiencing the yips. So she would have some kind of a response in the middle of a tumble or a jump or something where she lost her orientation. And again, this is for anyone who speaks in public or who's a musician and loses track of where they are. You know what this is like. You forget your lines if you do community theater. And she took time off. She was public and clear about what she was experiencing. And offered a great deal in support of the destigmatization movement. This is an issue because our colleagues, friends, patients don't like coming forward because of the continued stigma of mental health diagnoses. And Michael Phelps, also very public, the 25-time gold medal winner at the Olympics over his career, who has been very clear about the anxiety that he experienced in performance and the life-saving nature of his therapy. I mentioned here that Biles focused on mindfulness, this kind of meditation and self-reflective approach. I was at UMass for 18 years, University of Massachusetts, And Kabat-Zinn was there, who's the founder of this movement. And the campus at noon every day would take half an hour to practice mindfulness. It was a very calming period. So here the issue is the ethics issue for us as we try to analyze this is the discrimination and the prejudice and the way these kinds of things affect our patients and their access to care. So um, it's not always easy for our patients to come forward, and they're treated differently, obviously, by employers, insurers, um, risk assessors. We're in Washington, D.C. I'm talking with you from Washington, where people are employed by the government, and mental health is an issue in fitness for duty assessments. So very useful, very helpful for prominent and um, well thought of figures to be coming public, to be going public. In clinical care, we also have a movement in work-life balance. You may be noticing over the last few years, some of us are involved in physician health. Um, and the movement towards physician and clinician in general, this is not just for docs, but physician wellness is quite clear in supportive programs in many organizations and in support systems that are developed by physician health programs because we're experiencing burnout um, in our professions. It's certainly true in the pandemic. And you may know that this is something that's made up of emotional exhaustion, depersonalization, diminished sense of personal achievement, uh, a troika of symptoms that seem to overlap with mild depressive syndromes, and leads us to do trainings and teaching on resilience and how to overcome the stress of work. I offer you here a graph from one of the most prolific wellness teams. This is Shanafelt Derby. They were at Mayo for a long time. I think they're Colorado and Stanford now. In fact, Derby did a grand rounds for medicine a couple of years ago here, so we know her, and you'll see the bump here in 2021 of burnout symptoms during the pandemic. But this is stuff that we track both for young physicians, trainees, and for established clinicians. Now, the resilience hook is something that we teach in the refugee crisis. We have a GW Global Mental Health program here that works overseas. And the primary rule that we teach there is take care of yourself. Because if you can't take care of yourself, you're not going to be any use to anybody else who's experiencing trauma or burnout. We say put your oxygen mask on first, like they say on the airplanes. So there's a whole movement on resilience training that's come out of physician wellness and teaching coping strategies as we try to address work-life balance, particularly in clinical medicine, where we're trained to just work until we drop. And then, of course, there are systemic challenges which have been studied by government agencies, NGOs, academics. Um, for psychiatry, we experience shortages in treaters. And this is true everywhere. I mean, we're down 113,000 addiction counselors, 40,000 psychologists, 80,000 school counselors, depending on whose numbers you're looking at. And in our communities of color, we don't have enough clinicians to meet them where they are. So there's a good literature on same race, same faith treaters, which are enormously useful for marginalized communities. There's also poor rural coverage, as you may know, because our clinicians and our colleagues are all in the population centers in the big cities, and poor insurance coverage for any of you who know what it's like to get authorization for a couple of therapy sessions or a medication regimen that may not be mainstream. The American Association of Medical Colleges is also picking up that the graying of the workforce, as they call it, 60% of us are over the age of 55, and we're not generating enough psychologists and psychiatrists to make that up. And again, the Washington Post just last month adopted a well-known study to show that we have too few hospital beds in the country to meet the need. It was particularly a problem in public sector because we're the hospital, the treaters of last, the hospitals of last resort. And if we don't have the resources, if the public sector doesn't have the resources, no one else does. And this is governed by the issue of distribution of scarce resources and how do you distribute the limited funds that exist for mental health. Is it people according to their needs, people according to their contribution to society? Just recalling the pandemic, we diverted resources to nursing, paid them very well to stay employed during the pandemic. So how you make those choices, how you decide and where you put the resources. Again, do you put them in the rural areas where there's less access, or do you put them in the cities where there's already access, but there are more clinicians and more patients? I do want to touch on research challenges in mental health. I offer you here the now famous article by John Ioannidis, a fellow Greek, so it must be good. And he talks about the replicability crisis. There have been a number of studies in psychology, neurology, cancer research that were not being replicated. And his criticism was that it was the research methods that were inconsistent. The sampling was different from research team to research team. The definitions were different. The statistical analyses were not consistent. And we find this in our extremism research too. We work on primary source data in terrorism, and the definitions of terrorism differ by jurisdiction. You may know the definitions of lone and group actors differ. So it's very hard to get on the same page with our colleagues on different research teams. And for those of you who are interested in the technical aspects of research, we've been moving away from p-values, you may be aware of. So a number of journals and the American Statistical Association have been moving towards effect sizes and power rather than p significance null hypothesis significance testing. And in fact, some journals don't accept those anymore. And the reason my statistics friends at the School of Public Health tell me is that what you want is, given these data, what is the probability that my hypothesis is true? The problem is that what you get is, given the hypothesis is true, what's the probability of my data? Which is an entirely different question. So you'll see if you're doing research now or you're doing NIH grants, the hypotheses are first, there are data sharing requirements, and there's a focus on power and effect sizes. So a number of us are part of the Center for Open Science and these kinds of research communities that try to generate robust research. Finally, I want to talk about how we define things, because defining our terms is both an ethics issue and a science issue. You may know that the Diagnostic and Statistical Manual, which has the descriptions of the illnesses that qualify, is a reliability text. So it's essentially a checklist of symptoms, which is supposed to be in the context of a phenomenology. I mean, does this look like a depression? Is this an anxiety syndrome? But it was developed in order for us as clinicians to agree on whether there was we agreed on a syndrome or not. The problem is that it's not a validity framework. So if, like the rest of medicine, we want to be based in biologic, genetic background, a foundation, then we have to make a significant switch in how we talk about things, just what we call them. So validity is much more focused on neurologic, biologic, and genetic criteria. And in fact, if you look at what the NIH is doing now, it's focusing on what they call research diagnostic criteria. And there are any number of academics that support this approach in the philosophy of science. But what they've done here, I've offered you a piece of how they think about it. This is from the NIH's website. They're trying to develop units of analysis that are biologic or neurologic in character so that they can focus on behavior, genetics, and physiology, things that are much more concrete and that can be validated. The issue, of course, for our friends in philosophy of science is that the ambiguity of our current response, of our current approach, is that it invites social values to everything. And if you're a profession that deals in violence and sex and hyperactivity and all the kinds of things that are value laden, community values and the way we think about those behaviors influence whether someone qualifies for an excuse from work or disability. So it's a litmus test for what we value. I will leave it at that and look forward to our discussion later.
Thanks so much, Dr. Candelas. And now we will go to Dr. Fisher and your presentation. So I believe you will be, yes, there we go. Thanks.
Great. Okay, so I'm going to be talking about ethical challenges for mental health research and practice, specifically involving diverse populations, and I'm going to do so through three very brief case examples. So the first case involves Rafael Lopez. He's 15 years old. He's been referred to Dr. Jones. He was suspended from his soccer team for arguments with his coach and fights with his teammates, and as well as the fact that teachers have complained that he's impulsive, defiant, and disruptive in class. When Rafael talks to Dr. Jones, he tells her he's angry at his coach because the coach hates Mexicans, and that's the reasons he's been benching him, that he only fights with his teammates because they call him an illegal immigrant, and that the teachers think he's stupid because he speaks with an accent. So the first ethical issue is, how do we avoid harm from two common cultural diagnostic missteps? The first is cultural misattribution, which involves underestimating the role of culture. That is, simply applying a DSM or other diagnostic criteria without considering cultural issues, and this might be known as the universal diagnostic approach. But cultural misattribution can also occur when we overestimate the role of culture and ignore the fact that there may be other diagnostic criteria that are important, and this might be called the relativistic or relativistic diagnostic approach. So how do we bring these together so that we can diagnose, but with cultural awareness? So we do that through kind of four interlinked ways of thinking about Raphael's problems. The first is, of course, we think about standard diagnostic criteria. In this case, probably we are moving toward externalizing disorders. But at the same time, we have to be competent enough to know whether or not there are specific cultural expressions of the DSM or other clinical symptomology that we need to be aware of. We can't ignore the impact of discrimination on mental health. But at the same time, we can't assume that Raphael's responses are normative, but we need to be competent enough to know what are normative and maladaptive responses to discrimination that may then be linked to his externalizing disorders or other symptomology. Finally, when it comes to Raphael, and I said these cases are brief, We want to think about, if you are addressing discrimination in treatment, how do you reimagine it in a way that's appropriate for minoritized populations? I bring forth a theory for French and her colleagues called radical healing for communities of color, in which they argue that we need to avoid treatments that are primarily focused on coping, that is, reducing stress in response to discrimination. The reason for this is that by simply focusing on stress reduction, we may be implying to Raphael that he has to live with systemic discrimination and that it should be considered an acceptable part of his life. Rather, French and her colleagues suggest that we need to gain the skills to help Raphael cultivate his sense of cultural pride and encourage participation in community activities aimed at resisting discrimination. My next case involves addressing ethical issues in gender that's related to gender and cultural values in trauma-related treatment. So Irina is 19 years old. She's an Arab American woman. She's been referred to Dr. Matthews after an ER visit following a subway assault. The hospital staff suspected sexual assault, but Irina and her parents declined the rape test. Irina attends the first session with her parents, which is a big surprise to Dr. Matthews because Dr. Matthews is not aware of certain Arab cultural values where family cohesion is extremely important. However, she rises to the occasion and she obtains Irina's permission for her parents to join part of the session, but also informs them that this will be followed by a private conversation with Irina. So what are the presenting concerns? Irina's parents are very angry with hospital staff for bringing up sexual assault, and they demand that Dr. Matthews not discuss any sexual aspects of the assault if they arise. In private, Irina also requests that sexual issues not be discussed, and she explains to Dr. Matthews that in her small cultural community, victims of sexual violence bring shame to their families and are often considered ineligible to marry. So the question here is, should Dr. Matthews take on this case? So how do we do good and do no harm? What does Dr. Matthews have to be thinking about? Given the ER's suspicions, can trauma-informed treatment work if the possibility of sexual trauma is prohibited? Are there cultural factors that could make exploring sexual assault issues harmful to Irina's mental health? And is Dr. Matthews prepared to help Irina navigate family and community reactions if sexual assault is discussed? We also have to make sure that Dr. Matthews avoids this cultural misattribution that we spoke about before. She has to consider culture and become familiar with how Arab American cultural values like honor, religion, gender, modesty, and how these may be shaping Irina's and her parents' concerns. But she can't be totally relativistic. She also has to think about, are these concerns about sexual issues merely cultural, or something else that she would be asking in any kind of family situation? Or whether or not Irina's concerns stem from trauma-related factors. So this is the way we can put together both a universalistic and a relativistic kind of approach to symptomology in a way that's culturally appropriate. Finally, we have to be thinking about informed consent here because that's what this first meeting is about. Does Dr. Matthews, Irina, and her parents have different conceptions of the goal and nature of therapy? Maybe they don't understand Dr. M's confidentiality obligations. So Dr. M has to figure out, can culturally competent informed consent harmonize these expectations? So we get back to the question, should Dr. Matthews take Irina as a patient if she insists that sexual abuse should not be discussed? So I'm not going to leave you with any answers, of course, because these are ethical dilemmas. But I am going to leave you with the fact that ethical principles don't solve all our problems. They're actually a double-edged sword. So when we think about respect for rights and dignity, a core ethical principle, we have to ask, does Irina's autonomy right to consent or dissent to treatment also include directing the treatment approach in ways that may be antithetical to professional competencies? In terms of doing good and doing no harm, we have to ask, is partial trauma care better than none at all? Or does avoiding sexual topics reinforce shame and exacerbate trauma-related symptoms? And finally, in terms of integrity and trust, should Dr. M accept Irina's condition while anticipating that, well, once she builds trust, Irina may later permit discussion? Is this being a lack of integrity in terms of the informed consent process? So finally, I'm going to turn to research and ethical dilemmas in suicide risk research involving Black young men. Suicide is the third leading cause of death for Black males, 10 to 24. Research indicates that discrimination is significantly associated with depression and suicidality. A DBT therapy, which I'm sure all of you are familiar with, has been found to be effective across a range of effectiveness in reducing suicidality. However, the majority of research is with white males, and research that has included Black males has very small sample size or mixed effect that indicates that DBT may be less or actually ineffective for Black males. So Dr. Simon wants to do a randomized clinical study, and what he's going to do is he's going to recruit Black male young adults who have been recently hospitalized for a suicide attempt. The reason is that the year following release from the hospital for a suicide attempt is the highest risk for a repeat suicide. He's going to have two arms of his research. He's going to have the standard DBT, which focuses on cognitive, behavioral, and interpersonal factors. And then he's going to have an arm that adds to the DBT cultural factors such as coping with racial stress, critical race consciousness, and cultural authenticity. The treatment's going to last for 6 months, and there's going to be a 12-month follow-up. So one of the first issues that has to be addressed is clinical equipoise. That is there honest agreement in the research and professional community that DBT and DBTC are equally effective or equally ineffective treatments for suicidality among Black young men? Because according to clinical equipoise, you cannot run a randomized clinical trial if you know one arm is going to be more successful than the other. However, we also have to question the assumption that racial consciousness therapy would benefit Black young men with depression and suicidality. So even though radical healing may be an approach that's helpful for Raphael in our first case, for somebody who's suffering from depression, talking about systemic discrimination may increase hopelessness, which is particularly related to suicidality in this vulnerable population. Finally, we have to think about informed consent and what I've called the autonomy welfare paradox. What do we have to tell these young men when we're giving them informed consent? First of all, we have to tell them that they were recruited because the 12 months following hospitalization is a critical period for a repeat suicide attempt. Then we have to say that there is a current lack of evidence of treatment effectiveness for Black young men, and that suicide attempts among participants are one of the measured study outcomes. And of course, we're going to be adding all the risk protection information that is appropriate in this situation. But why is this an autonomy welfare paradox? Well, does the information contribute to participant empowerment because they're knowledgeable now about their risk, or hopelessness, which might increase suicidality? How might this information affect those who refuse to participate? Do we have an ethical responsibility to participants who refuse to be in our studies when we've informed them of information they may not have otherwise been privy to. And finally, considering relational autonomy, should a relative or close friend be required to attend the consent conference to mitigate against these potential harms? So leaving you with these questions, I just want to conclude with the question of how do we do good well? Well, openness to others when working with minoritized populations is considered a core virtue for researchers and practitioners. It requires flexibility to respond to the patient or participant's definition of culture. It requires self-reflection on the effect of our own experiences, knowledge, and biases on good practice and research. And it also requires the courage to counter implicit biases in the profession. Thank you, and I'm looking forward to the panel.
Thanks so much to you both. The examples were fantastic, Dr. Fisher, and I think we've got a lot of questions in response. And Dr. Candelas, we certainly have a bunch of questions for you. They're under Q&A here on the Zoom. And I'd like to start out actually, since a few people have asked about it and a few people submitted questions in advance, the issue of digital mental health tools, apps, AI-driven platforms, and what new ethical challenges come with these tools, AI therapy or online surveys. And I believe both of you would be great in responding. Thank you.
Okay, I'm happy to start. I'll talk about a couple of things that are related to both research and practice. One is chat boxes, robots, semi-robotic therapy, all these things that are coming into play. I mean, there's many ethical issues, and I think Dr. Candelas has written about some of them. The ones that I would emphasize is there is no guards against an error. When the chat box, the robot, or any kind of AI therapy makes a mistake, who knows about it? Remember that the AI is constantly learning about information, but their knowledge of making a mistake may be very different from our knowledge of making a mistake. And so, we know the more popular issues that have come up with the AI really did not detect that suicidality was something that these young people were talking about. So there's no checks and balances with respect to an error that's made. The other issue is the confidentiality issue. When you're using any of these instruments, there's a company behind it that's providing this platform. And that company is collecting all of this information. And so that's another issue. The third issue I'd raise has to do with research and the use of mobile health now, mHealth, the things we wear on our arms. And if we have a mental health disorder, for example, we may want to be alerting people to take their medications. We've done some research on people with HIV and mental health disorders that demonstrates that sometimes that makes them more depressed, that they're looking at these questions that they have to answer about their mood, and they're getting very depressed about the fact that they have to be, it started a rumination process for them. So I'll just leave it there because I'm sure Dr. Candelas has a lot to say.
No, that's great. We agree. And, a lot of the professional medical organizations are taking a look at this now. I mean, to what degree is AI involved in treatment and treatment planning and diagnosing? And there's some places where it's good, but other places where it's untested. And I too worry about the company behind the technology using the information, because there's no protections for that. So research, we have to see how useful this is in an era of scarce clinicians, scarce mental health clinicians. Are we going to move to these softer versions of treatment when there aren't the outcomes studies? So right now, if you look at the organizational guidance from World Health Organization, UNESCO, the big universities, it's all principle based. So how do we approach treatment using AI technologies? We have to value privacy. We have to value confidentiality, transparency. all these kinds of things. We're starting at the beginning. There was a question in the preliminary, in the run-up to the webinar about how we can keep up with technology. And the short answer is that we can't. We didn't do it in genetics. We're not doing it in technology, which is why we're scrambling to come up with the guardrails that Dr. Fisher is talking about.
I would add one more thing that we haven't really explored what it means, and for our children as well, to have therapy with a non-person, and what kind of interpersonal skills are being depleted, and what kind of, they now have these robotics for children with autism. And when you think about that, these robotics are being used to increase their social skills, but they're being used to increase their social skills with a metal person. And so I think that's another issue that we're going to constantly have to approach. What are human interactions? And are they being depleted by these relationships with AI?
Thanks so much to you both. It's really a lot to think about, particularly the fact that we can't keep up, right? So, and we certainly can't predict what's next. And all we can do is try our best to address issues as they arise. And unfortunately, that tends to be crises, right? Moving from one crisis to the next. We have several questions in the Q&A related to other cultures, low-income countries, global issues, and you both touched on this. For instance, let's see, we have one attendee from Mumbai, India. How can we combat ethical challenges related to cultures we are not personally exposed to? And then let's see, a bit above, let's see, we have questions about what actually vulnerable means. How do we identify it? What might that mean in different cultures? Things like that. And I know both of you are very interested in those questions as well.
Well, the question of vulnerability, I think, is really interesting because vulnerability is contextual, right? Somebody may not be vulnerable in certain situations in their lives, but we may make them vulnerable when they're in research if we're not doing the research appropriately. I've always argued that, for example, in research, that rather than putting the burden of vulnerability on the person who's our participant, the burden of vulnerability has to be how we're running our research, how the informed consent has been culturally competent, whether or not we've actually developed measures that are appropriate for that person and their lived experience. So I do think the issue of vulnerability is something that is not, should not be universally applied, but is a shared kind of result from both the practitioner or the researcher and those that we're serving.
Yeah, so much to think about there. Thank you. One issue first from for our guest from Mumbai, and when we work in Europe, we're working with communities, migrant, immigrant, refugee communities from Syria, from the Middle East, from Northern Africa. We're not familiar with all of the cultures. So we have cultural ambassadors. So either we have people who have remained in the country and are working for the NGOs, so they've made the trek and they know the culture, or we have academics who can teach us and be present with us, like interpreters, during the interactions with refugees, because they're on the beaches, we're on the beaches. We try to figure out the triage process for getting them into the camps where they have access to attorneys and the process. So I think that's an important issue. Vulnerability. I mean, there are traditional ways of thinking about it. I'm thinking how the AMA started writing about vulnerability when it made it an aspect of professionalism. That this is Matt Winya's work. both at AMA and now at Colorado. In terms of access being one down, in terms of the power and knowledge differential, the classic, the traditional ethics um, frameworks for looking at vulnerability. So if I'm thinking of it in terms of lack of resources or lack of access among marginalized or minoritized groups, maybe that's helpful.
Very helpful. Go
I
ahead,
would
Dr.
just
Fisher.
add in terms of research, in my area of HIV and substance use, international research has literally been cut in terms of NIH funding. And so one of the interesting ethical issues that have come up is the extent to which research now, if it occurs, will be even more largely funded by pharmaceutical companies and or the countries themselves. And so one of the questions is, number one, do we understand what some of those pressures are going to be? I think over the years we've understood what some strategic pressures might be from NIH, but now we're going to be encountering new pressures from governments and from companies who are going to be largely funding or initiating these studies. And I think for those in the United States, we're terribly unfamiliar with what those issues are going to be.
That's very helpful. I'd like to follow up that idea with how you both are thinking about changes in funding and how it will affect your areas of research or, the community that you work within. What does this mean for the advancement of science, the advancement of research, long-term, short-term? Have you been thinking about these issues with your colleagues?
Celia, I don't mean to put you under, get you going first every time. So let me.
Thank you.
I mean, our issue in Washington, D.C. and in public sector mental health is the pullback from advocacy and DEI and all the kinds of things that we thought we were on a trajectory for. Because if you do good research, you have to have good sampling, you have to have good representativeness, both in your research participants, but also on the research teams. So the perspective of the community is critical. I mean, there's so many communities that have been surprised by the kinds of research that are going on in their backyards, that it affects the politics of genetics research, of racial determinants research. So those of us who do this kind of work in public sector, social determinants, racial determinants, are worried about where we are now because it just won't be funded as easily. And we're just on the cusp of developing this work. We have the outcome studies now. We're just starting to have them that we can act on them. So when we did a traditional black-white study comparing black defendants to white defendants, we wanted to make sure that we knew our jurisdiction well and that we knew the research methods that would get us the truth of the matter. Because as Professor Fisher said, most of our studies are done in white males. There's a famous article by Rebecca Dresser 40 years ago now, wanted single white male for medical research. She goes, why is it? I mean, what happened to women's issues? What happened to minoritized groups issues? And this was right at the time when the NIH developed its women's studies program, so in the early 80s. So this comes with a new focus on these areas of research. So I mean, we're worried about it in public sector, and the research that's done in lower and middle income countries. We have a researcher here, prominent researcher, Brandon Court in global mental health, who studies exactly that. And I just can't wait to ask him what the recent political environment has done to his work.
Thank you. Dr.
I would
Fisher?
say, yeah, I mean, it's a real challenge for those of us who have been doing, disparities and equity research for a long time, but it's also challenging, right? I mean, one of the challenges is that we cannot do targeted research, which is very important, I think, as Dr. Candelas was talking about. If there's a specific problem and a specific population that has that problem, then we want to oversample that population. And at this point, that's not going to be permitted if we have NIH funding. And so the question really is, do we have to change the questions we're asking, or is there going to be funding for broader populations where within population differences can still be studied, but may not be the primary focus. So we will need larger populations in order to really understand whether or not there are these population differences. I think the issue that people in my field are facing, HIV, LGBT, drug abuse, is that so many places have lost funding. And what does that mean for mentoring? What does that mean for the new generation where their funding is either lost or they do not see research, for example, as a future? And what is our responsibility to them? What is our responsibility, for example, from an ethical perspective, when we can no longer promise confidentiality and be assured that our records are not going to be looked at? We used to be able to be assured of that, but in this particular time, that's not something that can be assured. So I think some of the promises that we've made before to our participants, recruitment can be a challenge if somebody is going to be identified by not belonging in this country simply through our recruitment measures. So I think there's a lot of ethical challenges that we now have to figure out how we're going to approach all this to protect our participants in the ways that we want to protect them, and to also conduct research that is going to actually have a result that can be implemented in the future.
Thanks so much to you both. I've really enjoyed this hour and getting to hear from both of you. I'm going to turn it over now to my colleague, Dr. Mbele, and we may have a time for another question, but certainly you may have one, Paul.
Yes, thank you very much, Melissa, and thanks, Celia and Phil, for those great presentations. So there is a question here that is directed to Phil. So Phil, you mentioned the issue of prioritizing those in need. And there is a very, very interesting and important question here, which says, so how can we ensure that prioritization does not end up as overtreatment or causing unnecessary harm, and especially taking into account the current political climate?
Yeah, I've been trying to get at that in the last 10 minutes. A very important question that requires the representativeness of the communities in that kind of research. It requires justice-based thinking. When I was an ethics student, we studied the Baltimore hypertension study. A couple of public health researchers from Boston came down and told Baltimore that the most beneficial way to access Black patients who had high blood pressure was to go after the people who were already in treatment. So they told the city this was their finding, and the city erupted. The papers went nuts. They're going, why would you give priority to people who already have access? And apparently the cost-benefit analysis and analysis afterwards ignored justice-based thinking, the access of the most vulnerable. And ultimately the solution was trucks, taking screening trucks into the poorer neighborhoods. So two things. One, the representativeness and making sure the community is represented. And two, making sure that there's justice-based thinking in the design. So maybe that gets us part of the way there. Dr. Mbele, I wonder if I can address real briefly this idea, which it's present in the Q&A and also in the pre-webinar questions. Mental health participants are not excluded automatically from research. There's an element of the Code of Federal Regulations, those of you who go through IRBs know 45 CFR 46, which is about research participants who may become cognitively impaired, right? It's not assumed that everyone who's an elder or demented or an adolescent or has a mental health diagnosis is incompetent. And in fact, this is what the MacArthur studies were about. The MacArthur Foundation funded a series of studies all across the country that showed that it's very difficult to predict who with a diagnosis, medical or mental, is going to be incompetent. You have to do the assessment. So the research may contain screens or consent auditors or prison representatives on the IRB as protective mechanisms. But even if you look at the big time, like schizophrenia studies, think about really severe persistent mental illness. The study out of Will Carpenter's group here at Maryland was, 30-35% could be incompetent, but that meant 70% were not. So we try not to paint everyone with the broad brush of incompetence.
Thank you very much. And in fact, that was going to be the next question I was going to pose. So now I'm going to move to a different question. And I'm going to direct this question to Celia, because Celia actually emphasized on the need for flexibility and self-reflection. So the question is, how can early career clinicians cultivate the flexibility and self-reflection that you mentioned, especially when working in environments that push for standardized protocols?
I think that's a great point. I think that's the last point of the virtue of openness to others is, should we be challenging the environments that we work in? If they're pushing simply a standardized approach, and we do not think that that's appropriate, it's probably appropriate for nobody. It's not appropriate for anybody to have a truly standardized approach. There always has to be some flexibility in terms of the lived experience of the person that we're talking to. Otherwise, it's just pro forma. So I think that we do have to challenge our professions right now. In terms of doing so, I think we can use standardized instruments, but then add on a cultural appropriate assessment. The problem is we don't know what those are right now, right? There's a few of them. Do we add that in the beginning? Do we add it at the end? I would suggest we standardized in the beginning, and then we move toward, just like we do in some other diagnostic categories, to opening it up at the end to have something more cultural. But the problem is we have to be culturally competent, and that requires continuing education on all of our parts to be able to understand how we take a multicultural approach to any population that we're working with.
Thank you very much. And let me take this opportunity to thank everyone that sent in questions through the Q&A function. I'm now going to give our two panelists 30 seconds to give their parting shots. So I'll start off with Phil, 30 seconds.
Great. I'd love to add something to Professor Fisher's response, because we write in terms of the habits and skills of the ethical practitioner. And self-reflection and flexibility are those kinds of tools that psychiatry, psychology are particularly interested in, so that we're good therapists, so that we're seeing what the patient's effect is on us. And Alan Dyer writes about this too in Psychiatric Ethics, that famous textbook here at GW. So I think about developing these tools as a matter of growing as a professional and developing the habits and skills of the ethical practitioner.
Thank you very much, Celia.
So I would just say that we also have to be aware that there are no cookie cutter answers to really important ethical issues, and that to do good well in our research and our practice, we have to be comfortable with this tension between doing good and doing harm, and constantly exploring different alternatives and choosing the appropriate pathway, and then monitoring and evaluating whether or not it's worked the way we wanted it to, so that we learn the next time what a better pathway may be.
Thank you to our two panelists, and thanks to everyone for those great questions and those great comments. So in the few seconds that are remaining, I'm going to give some updates regarding upcoming events. Next slide. Yes, so we are going to have our next webinar, which is going to focus on the ethics of organ transplants. And this is going to be on October 21st. And then we'll also have another webinar that is going to focus on ethical issues in pharmacoeconomics and drug pricing. And this is going to be on November 18. And then for our internal facing meetings, we are going to have a forum which is focusing on navigating the future of public health, the ethical implications of polygenic scores. And we're going to have our colleague Shomika talking to us about some of her work. And we're also going to have another one on November 4th, focusing on artificial intelligence and research integrity. So thank you all. So please look forward to those future events. And to our GW participants, please feel free to send in your professional enhancement or PE forms to our email account, and we'll be very happy to sign those for you as proof that you attended this event. Once again, thanks to our two panelists, Celia and Phil, for taking time to share with us your views on this very, very important topic. Let me also take this opportunity to thank everyone that has participated in this webinar today. From me and the team at the Office of Research Excellence and the Bioethics Interest Group here at the George Washington University, thank you all and goodbye.